Thank you, everyone, for joining our panel on the future of prior authorization with Agentic AI. I am pleased to see over 425 healthcare leaders join today, and we're going to speak about one of the hottest topics in healthcare operations right now, which is prior authorization. Some know it as pre-certification, pre-registration. The point is that healthcare as a whole is almost 20% of the US GDP. And we're going to talk about healthcare technology all day and bottom line for healthcare orgs and efficiency for rev cycle teams. But as we all know, the number one reason we're all here today is because it impacts patient care. So this really matters. And today, it currently takes 16 minutes to manually process one prior authorization on average. It currently, at 37% of denials are directly tied to prior authorization, registration, and eligibility manual errors. So doing this solely manually is not the way forward. So let's get into what we can actually do about it. So the agenda for today, I'll do some intros of the people here today. Excited to have you all. Then we'll get into the current state of prior authorization, what's really going right and wrong, the cause of delays and denials, and how this actually is attributed to denials, communicating the ROI and the impact around prior authorization, and what it means for other pieces of the revenue cycle when it's done correctly versus incorrectly. Then we'll cap it off with the Q&A. Without further ado, let me introduce Zia Buddha. He is the CEO and founder of OpenBots. Zia is a serial investor and entrepreneur in the automation and healthcare technology space, and he has a very big vision of making healthcare revenue cycle management as autonomous and streamlined as possible. Zia, any words?
Good afternoon. Thanks, Gabe, and very nice of you to have me here. I'm very excited to be here. Prior authorization is actually the number one thing that we are solving for. So this is a very exciting panel. It's a very exciting discussion for me. So thanks for having me.
Absolutely. Nice to have you. And next we have Ranodeb Banerjee. He goes by Rano. He is the Associate Director of Healthcare Automation here at OpenBots. Rano, any words?
Thank you, Gabe, for having me. And it's lovely to see Jonathan, Zia, and you too, Gabe. Yeah, I'm very excited. Like Zia mentioned, it's like one of the big problems across revenue cycle that we are trying to tackle with Agentic AI. And I'm quite excited to speak about this topic today.
Excellent, excellent. And next we have Jonathan Leon. He is a senior healthcare process architect at Accelirate. He's a former systems analyst at Nicholas Children's Health System. He has experience at Baptist Health, but really he combines a deep expertise across revenue cycle management and healthcare automation that really helps your clients, I'm sure. And he works at Accelirate. Accelirate is one of the leading automation implementation companies within the healthcare industry, specifically focused on healthcare providers. Jonathan, any words?
Appreciate that intro. Very nice, sir. No, it's always great to collaborate. I really enjoy sharing what it is that we can do to those in the healthcare space. Just with my experience being actually working on the provider side, our tool set was limited. But now being outside and working with companies such like ours, I'm excited that there are other tools that these organizations might not be aware of that can really impact and improve the way they're operating. So it's always great to be able to share this information with those in this space and let them know that there is a brighter side of things. So thanks for having me.
Excellent, absolutely. And myself, my name is Gabriel Skelton. I am the head of artificial intelligence solutions here at OpenBots. OpenBots is a platform designed to help healthcare providers run their rev cycles autonomously. We have a deep focus on automating referral management, eligibility verification, claims processing, denials, prior auth, and all with agentic automation. I think it's important also to define agentic automation as we're all here and hearing about it. Really, all it is automation with reasoning. The fundamental difference that large language models have enabled is reasoning for automation. That's a game changer for prior authorization. Whether you're submitting the prior auth and then monitoring the prior auth and automating all of that, there are higher IQ tasks that are not possible as well. For example, you can have an AI agent actually sift through clinical notes and documentation accurately, swiftly to streamline things. So for anyone who wants to learn a bit more about that, we'll put a Google form in the chat. You could drop your name and your email, and we'll get to you there. All right, and then we'll cap off with the Q&A. So let's get into the first question, Ronald, for you. RCM teams are operating in a very siloed way where the majority of low IQ processes are still manually executed by subject matter experts and people who have very strong expertise in the industry, taking a lot of time here. And currently, 94% of physicians agree that manually processing prior auths cause delays. So the question to you is, tell us a little more about the current state of technology in prior authorization. Why has it taken so long to fix it, and what's going on today?
Yeah, I think a surprising stat that I was seeing, Gabe, from American Medical Association that mentioned that nearly 40% of the prior authorization request submissions time is spent on navigating between payer portals, EMRs, entering information from the patient's chart into the clearinghouses or the payer portals, and kind of tracking down the status of the prior authorization request on different payer portals. Once again, it clearly shows that a lot of time that is spent on is kind of like repetitive, but more importantly, low value in nature, which simply automation can do in today's world. Now, why hasn't this landscape changed in the last few years or even a decade? I think there are a lot of nuances if you think about a payer, from a payer standpoint. What specific rules United Healthcare follows is not going to be the same for what Aetna follows. So there are different rule sets, there are different guidelines that a payer has to kind of follow for not just medications, but also the procedures and the drugs, which is going to be ordered by the provider groups. But more importantly, one of the things that we have seen is that, it's literally the time this prior authorization teams spend on the payer portals or on the EMRs, which is literally staggering. I mean, you log into a EHR as a prior authorization team member to find the right patient. You go into the demographics, you find the insurance information. You then try to go into a clearinghouse like Availity or a payer portal like United Healthcare. You run those eligibility checks. You then try to submit all the sufficient documents that United Healthcare is requesting for the authorization that you're submit for the order that you're submitting. It is quite a back and forth. It is something that which should be solved, and once again, I think that's another area which we as a team at OpenBots we are trying to solve by bringing in Agentic AI.
I love it. Very interesting points. And even Jonathan, what's interesting is that it's actually very hard to get data around prior authorization because it's done so manually and there's such little monitoring around it. But as of today, I believe 24% of denials are directly attributed to registration and eligibility. Additional 13% can be directly tied to prior auth, making a little under 40% of denials really on the front end directly tied to prior auth and registration eligibility. So tell us a little more, like what's going wrong operationally? What's the state currently there?
I mean, so I guess kind of what we were just saying, even Rana was saying, like that it's a lot of manual processing that takes place. I mean, at the very beginning, it's an exchange of information between the patient and the organization, the provider's office, what have you, just for their demographic information, their insurance information. I mean, the verbiage even at times isn't even always the same. It's like your member ID, your subscriber ID, this and that. So a lot of manual collection of information is provided from person to person, and then it's documented into an EMR, EHR system. Misspellings, incorrect numbers, fat fingers happens all the time without even notice. From there, just kind of like we said, it's from one system to another. It's logging into other systems, so it's a lot of data capture. I would say is the very beginning pain point, and then from there we can move over to communication. So we have all that entered in normally, but the the scheduler would probably be the first person doing all this data collection, but it's going to be probably someone with an authorization unit or an authorization specialist would be the one to really go through that process of obtaining the prior auth. At times, they might need to refer to a clinical team member to obtain some more documentation, some more justification to really satisfy why a procedure, a study, a medication is required. So then another set of communication between two other team members. So between all those different interactions, person to person, and then really trying to get everything documented in one place, a slew of errors can happen. So I would say that's, communication breakdowns, probably the second challenge. And then thirdly, like we touched upon, is just on the payer side. There's so much complexity and variability that can happen. Things can change at any given time without really true notice. So what someone on the auth side might know one day can completely change the next day. So then there's that research to ensure that, does this procedure, medication, study require a prior auth? If so, what sort of documentation is needed to satisfy or to help make the decision? Just really understanding the guidelines, really doing all that research to ensure that that initial submission of that prior auth is done cleanly, because if not, it's going to be a lot of back and forth, which even there's no true indicator as to when a response is provided. So yeah, data capture, communication breakdowns, complexity, and variability.
No, absolutely. And I mean, I think there's a stat about 33% of patients abandon treatment when there are prior auth issues and delays. And we talked about how I think it's like almost like 94% of physicians say that it delays care. It's basically everybody. So Zia, I'll kick it to you. I mean, the issues that Jonathan and Rano are talking about, like, is this a clinical issue or a financial issue? Like, what's going on here?
Well, I think it's a clinical issue with eventually impact, obviously, on patient well-being, as well as it becomes a financial issue. So if you have delayed treatment, which prior authorization process generally leads to, you can have disease progression, you can have complications, and you can have hospitalizations. In addition, some procedures, require repeat prior authorization, so that can affect continuity of care. So it's, and eventually all of that turns into a financial impact, because it increases the long-term costs for payers and the healthcare systems, and patients may also face, higher out-of-pocket costs. So one leads to the other. But again, if we go back to the original mission of, patient well-being and patient care, primarily, if we don't do that right, the financial implications, will always be there, and they are huge in the case of prior authorization.
Well said. And I think today, I mean, what's happening is that, I think, Ronald, you alluded to this, providers are logging into 4, 5, 6, 7 different systems. There's so much swivel screen just to submit and manage prior auths. Talk a little bit more, Ronald, if you don't mind, about how automation kind of unifies this, and even like things like turnaround time. Like right now, one of the best metrics we have for our clients is compare the turnaround time you have manually processing a prior auth to what it is after automating. That's a great metric. And also, it's not just about automating like the submission of a prior auth. Like, what if that data is incomplete or incorrect? You need to make sure that there's a check there before the auth is even submitted. And that way you automate in a way that's a little bit more intelligent and agentic to make sure you have as much efficiency and accuracy as possible. But you can talk a little more about that, Ronald.
Yeah, absolutely. I think there is a combination of automation and agentic AI that comes into play if you're looking to automate prior authorization. I think you touched about the provider or the care team logging into 4 to 6 different systems. Let's start with the first one, the EMR. I think automation bots these days can simply be integrated with EMRs using API, or you can log into an EMR with an approach called user interface automation, which simply means you have an automation bot with its own set of credentials to log into an EMR. It can very quickly go into the patient's chart. It can essentially identify who is the primary medical payer. It can simply go into the patient's chart and collect all the recent medical records. I mean, every single thing that you do in an EMR is just like a streamlined workflow for an automation bot to perform within an EMR. Now let's go to the other type of systems that we are going to interact with. It is either going to be a direct payer portal like UHC, or it is going to be a clearinghouse like Availity or One Health Port. Once again, if you want to use automation to log into Availity, or if you want an automation bot to access United Healthcare with a set of username and password and one healthcare ID, it can simply do that. It can essentially go into the interface of the payer. It can identify what the payer form looks like. It can understand what sort of information it needs to submit to that particular payer in order to satisfy, if I may use the word satisfy, the demands that the insurance company is making before it can approve whether they're going to give an approval to the drug or the medication or the procedure. Now, essentially, you are kind of submitting all the data that you need to submit after going through the patient's charts. The area where you would need agentic AI is perhaps identifying what the insurance company wants. In many scenarios, the insurance company is not straight away going to approve a drug or a procedure or a medication that you have requested for. Agentic AI comes into play, in my opinion, when a common drug or a medication or a procedure that is requested by the provider is already available in LLMs, large language models, that this kind of orders of a medication, of a procedure, has been previously denied by this particular insurance company. This kind of knowledge can easily be baked in to an AI agent, so that the AI agent, instead of, without brains going into the payer portal or clearinghouse, instead of it submitting the prior auth documents, it can escalate that situation preemptively to a particular prior authorization team member and request the team member saying that if you want to submit the order for this particular drug, then according to the historical scenarios, you always had to submit some proper documentation, or you had to justify the need to use this drug. And once again, this ties you back to the denial solving case, because you are straight away saving the denials in the first place, instead of just waiting for the insurance company to come back to you after 7 business days and tell you that, hey, we won't approve this particular medication because that simply doesn't matches with our guidelines.
Well said, because there's distinct payer rules for every payer. But what you're saying basically is that it's bringing organization and structure to the process of submitting and monitoring prior authorizations, especially because you can start getting more predictability on how it happens. So, Jonathan, question for you. I mean, the question is, how often do you see prior auth delays causing cancellations and no-shows? Tell us a little more about the downstream revenue risks. And a comment there is, I mean, of course, it changes for every segment of healthcare. Like some of the segments that have the highest volume of prior auths are radiology, oncology, cardiology, ortho, and it changes. But at the same time, regardless of segment, it's crucial to make sure you get the prior auths either before the appointment happens or shortly after.
Yeah, so with this one, percentage wise, I don't know a number off the top of my head. I'll be honest, I had to do a little Googling myself on this, but it's said on average is about 15 to 25% of I guess scheduled appointments kind of are canceled or no-showed because of prior auth issues. From my experience working at the hospitals, I do know it was such a large concern that dedicated work lists had to be created for those canceled and no-show patients. Because it's something that the organization wanted to reassure that the patient does get rescheduled, does reappear for that service, because if not, then there is a financial loss to the organization. And the most important part, the patient themselves, they're not even getting that type of care, and they're probably having to find other means of going about that. So I would say, yeah, prior auth is a big issue with regards to that. And then as an organization, the customer is obviously the patient. You want to give them the smoothest, the best experience you can, but with something related to this, it puts a bad taste in their mouth. From a regular person who's not really in the field, they just know they have insurance, so for the most part they feel they're covered. So when they present all that information, they're making their appointment for services, medications, whatnot. They don't want to really know about the behind the scenes of what the problems are. They just feel, let's go ahead and get this taken care of. So now that there is that delay or there are issues, and most likely they will be contacted about it, it just gives, again, it gives that negative experience, and then now starts giving a bad look to that organization. Therefore, that, if the issue can't be resolved within time, then it's going to lead to a cancellation, which the cancellation is an administrative burden now on the organization, because it's going to have to be rework that would have to be done to reschedule the patient. Depending on how long of a time frame it would take to reschedule that patient, the initial prior auth might have lapsed. So then it's going to have to be a new authorization process, again, submitting the documentation and all that, which hopefully what was already collected is fine. But if things change on the payer side, it's now new guidelines, new requirements, new research to determine what else is needed to satisfy the need there. So it's a big issue, affecting both patient and the organization or office, and the amount of rework or the time dedicated to it can definitely have large impactful revenue risks. From the no-show standpoint, I think that's even worse, because it means that everything was let's say everything was lined up. Now a patient no-shows for whatever reason, but now that's resources that were dedicated and reserved for that specific appointment or time frame. Um, that now is lost. So the organization loses out on the revenue there, where they could have fit someone else in. Now it's just time wasted there. It's still administrative rework, because they'd have to reach out to the patient, try to get them rescheduled. And again, given how long it's going to take to reschedule them, it might have to be another pre-auth process. So it's a large issue. And if automation can get a hand in there, it'll alleviate so much burden from the teams to really kind of keep up with the workload that's presently in front of them.
Very well said. I mean, I 100% agree. The level of administrative burden, the rework, how initial auths may have actually lapsed, because it could be a few months and now you got to get reauthorized, basically, because maybe you were authorized in March, but then your insurance is up in May. So absolutely, it's a huge thing. In question for you, Ronald, before we do, I want to highlight a couple of the comments that Lee has shared. I'll put it here. So he mentioned oftentimes providers and mid-levels don't know the codes to get the prior authorization for the procedure. Automation can help. Each payer has specific codes to get the PA. And next he mentioned you want the authorization before the appointment is scheduled. That's a standard rule for the front desk. And if the PA is not obtained and the patient is seen, the patient can easily end up with a bill, which definitely happens in a lot of segments of healthcare. And that's not the ideal way for the provider that may not get paid, or for the patient who's a huge bill that they have to now interface with. So next question for you, Ronald. So it goes along with Lee's comments, is specifically, how does Agentic AI decide when to escalate a prior auth manually versus just processing automatically? What happens? Because the reality is you can't just automate it and have no people. You need people for this, right? People are crucial. They're the most important piece of this. But how does that change? Tell us a little more about that, Ronald.
Yeah, I think I just want to, kind of continue with the same question that is asked in the comment section. Let me give you a few examples where agentic AI can escalate the process, and which obviously an automation bot cannot do. If you think about prior authorization, you have to first think about even insurance eligibility. You need to understand that the patient has the right insurance plan. It has the right coverage for the insurance payer he is paying. Now, a agentic AI process would be like this. It can easily go into the patient's chart. It can identify who the primary medical payer is. It can essentially look into the insurance information, and it can immediately do an eligibility check by going to that particular specific payer and notify the care team whether there is a mismatch in the insurance information based on what is reflected in the EMR. And it's a very, very simple process, but this can have massive consequences. You simply cannot go into billing and other pieces without identifying whether the patient has the right insurance coverage or not. The second piece where I think agentic AI would play a huge role, and it's already kind of taking shape, is, think about this. If you are ordering for a high-cost drug from United Healthcare, And United Healthcare has a threshold on the cost it can absorb for giving a drug, then an AI agent can be deployed in those scenarios to flag those situations where it can straight away tell the care team that right now you are trying to order a high cost drug, but historically speaking and logically speaking, a payer, let's say like United Healthcare, won't allow you this particular approval for this drug because that is going beyond the limits or the capacity to which they can absorb the cost. Once again, an automation bot coded in rule based logic won't be able to do that. And finally, like Jonathan was saying, an AI agent has some context to the payer specific rules and guidelines. It also has the context on the commonly used drugs and medications and procedures. And particularly in the field of oncology and orthopedic groups, where prior authorization is a very not only time sensitive process but a very cautious process, if I may use the word cautious here. During an oncology or radiology approval process, when you do a prior authorization, it is super important to know that the medication or the treatment you're requesting for historically has been approved by the payer or not. Because if it isn't the case, then at the end of the day, the insurance company is going to come back to you after 3 days and simply request you for either additional documentation, or in certain situations, it can request you for a peer to peer intervention, which means they want to talk to a doctor who is requesting this particular medication in the first place. Now, if you use an AI agents in all these three scenarios, it can escalate it, it can hand this off to a right particular member in the prior authorization team who can simply work on the clinicals and be better prepared to kind of justify the reason for ordering those PAs in the first place, instead of just sitting back and seeing what's going to happen in the next 10 to 15 days.
Absolutely. And your point is basically technology is getting advanced. And even though as advanced as it's getting and much more that automation can do, some of the problems are the exact same that have existed for a long time that have not been solved. So a question for you, Zia, for CFOs evaluating ROI, is prior auth automation about FTE savings, denial prevention, or something broader? Tell us a little more about how CFOs should approach this.
Yeah, so I think for CFOs, and for that matter, even for CEOs, I think it's not just the FTE savings or denial prevention. I think it's like anything else. There's, you have to look at things quantitatively and you have to look at things qualitatively, right? So you have to look at things like operational efficiency, revenue integrity, and patient throughput. So if we look at just a high level, if we do a breakdown of the ROI in different buckets, yes, FTE savings, that would be the number one sort of quantitative measure. For example, if you have 10 people or 20 people or 30 people working on the prior authorization function, and if you can reduce that down to by let's say by a factor of 10 or by a factor of 5 even, I mean that's it's substantial savings. So that's a simple math. You also have to, if you think about when the machine is doing a prior authorization submission, and again, there's a happy path prior authorization, which is the simple prior authorization request, and then there is the medium and there's a complex prior authorization request. And let's say if the machine takes over, a whole bunch of it in the very first round and takes over the rest of it over a period of time, you have prior authorizations there that are being submitted faster, they're accurate, and they reduce and or prevent denials, right? So that's, again, a quantitative and qualitative benefit. And if then you also have, again, if you look at it from a patient standpoint, it's faster and successful patient throughput, right? And that results in an accelerated revenue collection for the provider. And now let's take a look at some of the other benefits. I mean, you have better patient care, patient retention. You manage the compliance and audit risks much better. And there is a reason for that. And the reason for that is that machines track and log everything. So whatever automation and AI is doing, it's tracking and logging, right? So it's providing a complete orchestration of the process that does not exist in an EHR system. Most EHR systems do not have any orchestration or do not manage the prior authorization process, right? This is where companies like OpenBots come into play, because that's what we offer. And lastly, if you look at all of those combined, I think the scalability of the operation, many providers that we talk to, they are expanding their operations. They are either bringing in additional practices, or doing through acquisitions, or just organic expansion of their practices. And scalability is a much bigger benefit from this. So it's the benefits for CFOs and CEOs are both qualitative and quantitative. I mean, that's the beauty of automation and AI.
Well said. It's fascinating that for smaller healthcare providers, they may have combined billing teams that are doing claims and prior authorizations, are doing eligibility and doing a lot of different functions, versus some of the larger systems have dedicated teams just to prior authorization. In both examples, though, honestly, we've seen that they're just surviving. They're just trying to keep up with the volume. And then when you're just surviving, when you're just trying to keep up with the volume and doing everything manually, it gets very difficult, as you mentioned, to focus on metrics and orchestration of the process and actually auditing things. Whereas when you automate a lot of that work that is low IQ and manual, you can make sure that not only the automation is running, you know exactly what the automation is doing. So if there's a break or there's an error, there's denial, and you don't fully understand why, you can get to the resolution much faster by taking advantage of that audit piece, which is huge. You have to monitor it. You can't just automate and execute and survive on a day-to-day basis. That leads very well into the next question, and I saw another question in the comments we'll address in a second. But Jonathan, what do you feel like? What documentation or steps slow teams down the most, and where do these gaps typically lead to denials when it comes to the front end of eligibility, prior auth? Tell us a little bit more about that, given your experience.
So really, documentation standpoint, there's the medical necessity. Just gathering that type of documentation is time consuming. So being able to track that down, to see if it's existing in the current system. If not, it needs to be obtained from the source. So either the history and physicals, any kind of labs, test results, all that type of documentation that needs to be collected to really provide that justification is one of the key pain points. And at times it can't be obtained by just, let's say, an auth specialist. It's going to have to go to a clinically driven type person, a clinical team that really understands the information and knows which is valuable to, when submitting the prior auth. I'd say also, even just like we've been kind of been touching on, the different steps of going in from one system to another. But let's just say once it's even submitted, there is no true response or easy response of knowing when the payer has provided an answer. So someone now needs to continuously monitor that site for that patient to see if a response of an approval or denial has been obtained. Given the workload there, that's something that's now has to be at the top of someone's mind, to be sure to continuously check for that. And that's just one patient. So imagine that at scale, it's such a huge pain point, which automation can easily assist with something like that. For denial types, I mean, of course, without proper documentation, there'll be some kind of a medical necessity denial, or just maybe even a request for additional documentation is what's going to have to be obtained. So that's now your rework, going back to the case, back to see what was submitted, reaching back out to clinical teams to say, okay, we need additional supporting information. So all these, kind of just what we said, are just major roadblockers for the teams. And almost to kind of touch a little bit upon what Zia said, or even what everyone's been kind of saying here. That team of, let's say, of 10 that's just kind of focused on a particular portion of the prior auth process, even if you just left them alone and you included a small amount of automation or agents within that process, that team of 10 can now work like a team of 12, 15, or even more. All depends on how much automation you include into that team. You've just upscaled the performance of what that team can accomplish in a given day. So instead of just breathing, they can actually get their heads much further above water and handle a more throughput amount of information in a given day. So like we've been saying, there's huge opportunities, even for just the clicks and navigations from site to site, to collecting information and kind of preparing the packet. That can all be done with all this type of technology, as well as doing the investigations. As someone's mentioned, yes, not everyone knows what codes require prior auths or not. An agent or automation can actually go out to the site, perform a CPT code search, bring back the results there, pass it on to the agent. So now the agent has that contextual information to say, okay, given this code and given this information, I now know what the next steps are, and it can go ahead and take those next steps. So it's really helping, working alongside people, making the days much easier, reducing, increasing efficiency, reducing errors, and just, to me, overall giving the teams breathing room. And I guess the one last thing I'd say on that, within this organization or this industry, it is a service industry, right? The patients don't really need to know what's going on behind the scenes. They don't need to be involved in all this back and forth and all that, kind of like something that Disney does. You don't really know how all these different areas of the parks get kind of filled with inventory and all that. They have a tunnel network below the parks where all the teams and all that can move, so that's really the behind the scenes. So that's something that I feel like providers also are trying to do as well, right? They want to make sure that all these back end processes, all this work behind the scenes takes place efficiently without really involving the patient and kind of not really muddying that experience. So with technology like this, you can really get closer to that feel where everything can happen. The patient can have their great experience, get a good feeling for the organization that they're working with because of the efficiency that's now happening behind the scenes.
Very well said, Jonathan. I mean, there's a trend right now, I think, in CFOs and heads of revenue cycle and directors of patient access and really just revenue cycle leaders in needing to know more about automation. It's not just about understanding, having the expertise. I've personally been so impressed by subject matter experts who are forward thinking enough to say, hey, how can we do this differently? Because it's almost like going from the BlackBerry to an iPhone. It's so different. It's like you're just completely changing the process, but it's what's happening, right? But even like what you mentioned, like a happy path, whether you submit a prior auth and it gets approved in 2 hours or 2 weeks, where's the monitoring behind it? Like who is monitoring this? And it's people. So automation obviously can't take bathroom breaks or sleep. It just empowers people to do better work. And I mean, some of the trends you see across things like payment posting and claim status reviews in the back end of the revenue cycle is extremely rules-based, it's extremely structured, and that's why it's often outsourced, which is in a lot of ways, okay, it's good because you can lower your costs and all of that. However, when it comes to prior authorization, it's almost always in-house, or maybe a portion of it is outsourced, but usually it's in-house because healthcare providers want control over it, and speed matters. Accuracy matters. Turnaround time matters. So you typically trust your in-house staff the most to do it. That's excellent, but that does mean your costs are bloated there because your people that understand your operations best are spending time doing data entry work, are spending time checking portals over and over again. As Ronald mentioned that stat on the amount of time that's being spent on patient portals. So Ronald, question to you. We talked about how it takes 15, 16 minutes to process one prior authorization on average manually. Tell us a bit more about how do you get that under 4 minutes, even under 2 minutes? Like, how does that happen?
Yeah, I think if you think about an AI agent and automation processing and prior authorization, instead of a human doing it, then an AI agent categorically should have 3 powers, if I may say. A power of detection, a power of submission, and a power of tracking, which Jonathan was saying. What is the power of detection? An AI agent should be able to understand that the medication or the drug or the procedure that you're requesting, whether it requires a prior authorization or not. And then once again, flag that over to the care team. The power of submission is essentially going into the payer portals and submitting all the necessary evidential documents that the payer wants. And the power of tracking is essentially AI agents going back to the payer portals during the scenarios when it is not a happy path, to Zia's point. You need to understand whether a payer has denied the prior authorization that you have requested for it, or it has approved it. Now, AI agents in particular do understand, because it has the context, whether a common drug for a particular payer can be approved, and if it is approved, whether the time frame would be 24 to 72 hours or it is going to be 7 business days. An AI agent has this context already behind the scenes. So instead of bugging the payer, instead of bugging the provider, and instead of specifically letting a prior authorization team member go into the portal to check the status, an AI agent can essentially identify whether the prior authorization request is of urgent type or whether the prior authorization request is a simple medication request. And it can essentially go and track the status from the payer portal. If it's a denied prior authorization, it can essentially follow up on that. It can essentially resubmit the documents. But at some point, where it needs to escalate to a scenario where a peer-to-peer intervention is required, it can also think about this particular scenario, that this is not a situation which an AI agent can handle. It understands that, and then it can hand off that particular process for a peer-to-peer intervention. So if you think about all the steps that I said, an AI agent is just like a GPT, right? When you ask a even subjective question, a GPT doesn't take 5 minutes to answer that question back, because it's already embedded with the type of context within the model. So you don't expect a GPT to wait for 5 minutes. But even if you think about a very experienced prior authorization team member submitting a prior auth, he or she will have to take the time to go through the clinical notes. He or she have to log into a payer portal like Eligibility or United Healthcare. He or she needs to do the back and forth between the different systems. So there is no way, or in no shape or form, they can process these prior authorizations faster than an AI agent. And even research or stats back this up by saying that if you are looking at automating prior authorization if you're looking at processing prior auths manually and it's taking 15 minutes, quite simply an AI agent or automation can do it in 3 minutes at max. So you have a lot of efficiency gains on that particular process.
Excellent, Rano. I think your point too is that on the front end, in the middle, there are so many unsolved problems. Everyone recognizes that this is a problem, and there's such few focus on actually solving it. So I think I'm going to get into one of my favorite questions, but to simplify, what we're talking about here is simply automating the work on payer portals, right? Automating the work within EHR systems, automating the review of clinical notes and documentation when you need to resubmit a prior auth, for example. That's what we're talking about here. So Zia, question for you. Why, across the revenue cycle, why is prior authorization one of the most ideal starting points for AI in healthcare operations? And what does that unlock next across the revenue cycle?
Hey, so we actually went to 3 health conferences this year. We went to HIMSS, we went to Vive, and we went to Becker's, and we had a booth. And I would say 6 out of 10 people that were stopping at the booth, or 6 out of 10 conversations that we were having, were around prior authorization. So it seemed like that was the one of the biggest pain points that exists in the provider space. So and why is that? So we think that prior authorization is ideal for AI because it's high impact, it's high friction, and it's got high potential for automation. So let's see why, right? So first, it's the process itself is somewhat structured, but it's fragmented. Okay, two sort of contradicting terms, but let's analyze that a little bit more deeper. So because you have a prior authorization, you're dealing with semi-standardized data, right? You're dealing with codes, you're dealing with clinical documentation, you're dealing with payer rules, and you're dealing with workflows that are highly fragmented, because you can have a fax, data coming in from fax, you can have phone calls, you may have to go to portals. So semi-standardized data across a very highly fragmented workflow. So it's complex enough to require intelligence, but not so unstructured that it's beyond today's AI capabilities. And the AI capabilities that exist literally, post 2022, 2023, after the LLM revolutions, are pretty much game changers for this, right? Because you can now read the charts, you can match criteria, you can autofill forms faster than the humans. This is an ideal use case for an LLM plus an RPA rules-based automation type of scenario. With RPA, you were limited to what you could achieve, right? With LLMs, you can actually do the reasoning, and you can get much more. You can get much more out of an automation that you deploy. The other thing, again, it's with AI and automation, as I kind of mentioned before, because everything is logged, everything is tracked. You have audit trails, but you also can take a look at measure your ROI with an outcome, like you can with a binary outcome. You can have an approved or a denied outcome, and then you can see the overall throughput by applying AI. So it's relatively easy to see the ROI, with a system that not just only orchestrates the process, but also gives you all the insights into the process, right? So and lastly, as I said in the beginning, we think it is a painful process to demand change. We think, based on our conversations, that most, I guess we can say for the patients also, but payers and providers, nobody likes prior authorization process the way it is. It is a pain, and anything that you can do to simplify that process, I think it's a win-win. And we look at it from a standpoint of, we want the providers to have control over the process. We want the process to be efficient. We want a high throughput, and we want accountability from the process. And you can achieve all of that with AI. And that's why this is a perfect use case for AI.
What you're mentioning basically is that, like, those that avoid technology, like those healthcare providers, they're going to stay the same. They're going to stay inefficient, bloated, and ultimately there will be patients that have negative experience or don't get the care they require. I have one more question, and then we'll get into Q&A that, again, relates to this. But going forward, let's say a provider does automate as much as they can within prior authorization, and this is open to everybody. What is the next area, in your opinion, across the revenue cycle on the front end or the back end that deserves more attention from automation, but doesn't always get it? Like, what else is also super important to automate?
Yeah, I would say one of the things, it might not be just for automations, but I think one of the other things that you get by deploying automation and AI is you actually get some intelligence that you can gather from within a process, and you can analyze that intelligence, and it can actually yield quite a few insights that can affect the overall process that you're executing. So I think that's one of the benefits of applying AI to RCM. The other things that come to mind is you also have, for example, one of the things that I mentioned about prior authorization is the repeat prior authorizations, right? It's not just the initial prior authorizations. I mean, if you have an hospital stay that needs to be extended, you need a secondary prior authorization. So I think that's another area where deployment of automation and AI can yield more benefits. And there's many others. I'd leave the room to others for to chime in as well. Rano, Jonathan.
Yeah, I think in 2025 we still see payment posting being a manual process, and it's mind-boggling that when you have a set of rules to look through, when you have intelligent document processing tools to find information from EOBs, you simply don't need a payment poster or a team of payment posting to go through those checks and balances and deposit amounts, and then essentially validate and reconcile payments within a clearinghouse. I think payment posting should be a process that has to be on top of the list if you're looking at automation. I think the other area besides payment posting and prior authorization, which should be talked about, is denials. I know we have talked about prior authorization, which is essentially one of the main reasons for denials to pop up with percentage hikes every single year. But I think revenue loss is a huge thing, particularly in the world of healthcare providers, where the profit margin is way too less compared to what you see from a payer standpoint. So if we can find a way to use agentic AI, use LLMs, or whatever the technology is, but we can address denials, I think that's going to be a game changer for healthcare providers who are particularly working with very small margins.
Yeah, it's a great point, Rana, because payment posting is a very big chunk of payment posting, and those type of processes are actually handled by offshore BPO type of operations, and there's thousands and thousands of people working in those type of things. And we think that the time has come that a lot of that work can simply be handled by automation and AI, and it can be brought in-house with more control and oversight. So a great point, Rana.
I guess I'll go down the revenue cycle line, and I will go to like case management. I know that team. So let's say the patient's been scheduled, they're admitted, they're now in the hospital, they're receiving care. But a team like case management needs to continue to monitor them, to document how the patient is, I guess, how their care is coming along. And they're still tied to a payer to provide additional clinical information, to continue to make sure the auth is still approved. So where I'm going is maybe an agent or AI to assist with the medical record summarization. As the longer the patient stays, the more documentation is entered in, and all that needs to then be reviewed by someone clinically driven to be able to summarize that and provide the context of what's going on to payers. So with an agent that would be able to collect and view all that information, provide a meaningful summary so that a person doesn't have to dedicate so much time to that. They're now just on the reviewing end of what was the output of the AI. I think that would be a huge time saver. Still ensure that an authorization is secured, free up time for those case managers to actually work through a lot more patients in a given day. And again, now you've just kind of went down the step from the next department or kind of revenue cycle area in line. So if we're going to start from the front, let's just keep going down the line and keep a clean flow of information going through.
Wow. Well said, Zia, Rano, and Jonathan. Very well said. I think it relates to the fact that 70 to 80% of healthcare data isn't structured. So you need a little bit more advanced technology to process all of that, which is kind of where we're at today. We're at that crossroads where there's going to be a very big shift of providers who stay doing things manually and providers who really focus on how can they innovate within their revenue cycles. Let's move on to Q&A. We have a couple questions here that we can get into. And before we do, those that want to learn more, feel free to check out OpenBots.ai. Feel free to message me or Rano directly on LinkedIn, or even my email is gs@openbots.ai. For the Q&A, so one question that we received was, this might be good for you, Rano, if you'd like to answer it. What about data extraction from clinical notes, EHR notes, using language models? Tell us a little bit more about that.
Okay, that's an excellent question. I think just to set up the context here, OpenBots is an automation and AI platform, and one of the main components that we offer is an intelligent document processing tool. Now, talking about language models, something that we have embedded with our document processing tool more than like 2.5 years back, is a tool that is applied in many different scenarios. I think one of the things that Jonathan said kind of takes me back to a use case that we are solving, which is summarizing the medical records and making sure that the clinical team is not spending time going through all the faxes that comes in, some of which could be 40 to 50 pages long. And it's like a waste of time, if I may say this word, for a clinical staff to identify whether the patient has some kind of psychiatric disorders, which is reflected on page 35 from the long list of 40-page document. So, we are using our language models in many different areas, in many different shapes. But I think one of the main things that we do is obviously scanning through all the faxes, looking for key information, and making it, I think summarizing it in a way which is much more ingestible for a care team to look at, rather than kind of, spending time on every single line of a large document. The other prime use case for the document processing tool that we have is in fact automating the referrals process. Surprisingly, patient referral management, which can be considered as the front line of revenue cycle management, is a huge process, and every single provider group needs to handle this. Obviously, we know in today's world there are different EHRs who has a very electronic and integrated referral management system, but we still see 70% of the healthcare providers we talk to still gets a lot of faxes from different groups, and they really need to go through those faxes. They need to identify who the primary medical payer of the patient is, but more importantly, is this patient even existing on our database or not? And if it's a patient who is not a part of our database, then we then need to essentially create the patient's chart first, even before we can create an order or we can do any kind of appointment scheduling. So we do have a document processing tool baked with language models. The use cases are many, but I would say referral process management, summarizing medical records, or even extraction of data from EOBs seems to be the prime use cases where this tool is getting applied.
Absolutely. We're almost basically up on time. So thank you everyone for joining. Just to recap, we discussed a lot about how, listen, everyone is aware and agrees that prior authorization is a burning problem across the revenue cycle. Denials are the highest they've ever been. I believe the average as of the end of 2023 was 12% on average, and many are actually higher than that. It's taking way too long. I think prior auth is the number one single most time-consuming task across the revenue cycle compared to everything else. And I mean, there's just so much silver screens, so much going on, and you need to incorporate things like automation for scalability, for speed, and to really help your staff not go and be burnt out. Thank you all for your time today. If you want to learn more, you can see my email in the chat, LinkedIn us, reach out to us, go to our website, OpenBots.ai. Looking forward to continue connecting and making waves and disrupting the healthcare provider technology space. Thank you all.
Thank you.
Thank you.
Thank you.